disclosures. Somehow I always end up being the speaker like right before lunch, like at every conference I go to. So maybe next time I'll request not to be between you guys and lunch. So see if I can get to my slides up here. So yeah, I have no disclosures. And what I'm going to talk about is I'm going to talk about mapping, and I'm going to talk about stereo EEG nomenclature. So the two may seem like the tale of two talks, and hopefully they're not both the worst of times, but I think they are related. And the main theme is that what we call things matters. So anybody who's grumbled about changing of the name from Rolandic epilepsy to benign epilepsy with central temporal spikes, and then, well, actually maybe it's not benign, and now we should call it childhood epilepsy with central, and now it's hard to even keep track of what it's named. But the point is, there's a reason why we call things what we do, and at our center, we've paid particular attention to any little thing that we can do to improve our workup of patients and our interpretation of stereo EEG. And so this is one of those examples that I want to share with you all. So just to kind of familiarize everybody in the room with what stereo EEG is. So it's a minimally invasive procedure that we use to precisely localize where seizure starts. You can see in the cartoon above, there is an electrode, a tiny wire. It has recording contacts all along it, and it allows us to sample deep structures as well as superficial cortex. And then below that is a reconstruction of how we might use multiple electrodes to try and suss out where exactly seizures are coming from. And these electrodes can both record and produce activity for mapping and seizure stimulation purposes. So here's an example of what this recording might look like. And sometimes we have patients that have over 180 channels where we are recording from. So, and unlike scalp EEG, where we're essentially along one plane of interpretation, we have three dimensions that we need to think about. Because we're recording from deep and superficial structures. And not only three dimensions, but we also have known circuitry. The more you do this, the more you understand how these areas are more interconnected or not. And all that plays into its interpretation. So as an example for what has been done in scalp EEG, that has all been standardized. And the big advantage of that is it allows data to be compiled, reproduced, effectively analyzed. You have a sense of, without even looking at where the electrodes are placed on video, you know where those electrodes are, and you know that you have some reliability from test to test in what you are looking at. And one of the things that surprised me when I first started learning about this procedure is that there is no standardization at all for stereo EEG. And in fact, some centers actually have multiple different naming nomenclatures within their one center, depending on who the care team is at the time. And I think that lack of standardization is prone to misidentification of electrodes, and then also can have issues with inter and intracenter interpretation. So as an example where I trained, this was the nomenclature. So it's single letter nomenclature. And in fellowship, we had a cheat sheet. It was a laminated piece of paper on the wall. And it told us as fellows, like, what is F? You know, F is somewhere in the frontal lobe. And targets could be mesial orbital frontal, lateral orbital frontal, cingulate. You know, you don't really know. So I kind of got frustrated after a while at the vagaries of this single letter nomenclature. And so I took that piece of paper and I put a little picture of a rainbow on the brain, and I put somewhere over the rainbow, you know, as over here. So I just think that we can do better than single letter. The only publication that I'm aware of that has actually looked at stereo EEG nomenclature is from the group from Boston. And just kind of using the frontal lobe as an example here, you can see there's 3 electrodes placed in the inferior frontal gyrus. And what they do is they call F3, so superior middle frontal gyrus is essentially 1, 2, 3. And then the different electrodes are given either A, B, or C, depending on their relative location to other electrodes in that area. So you could actually take those 3 electrodes, which seem to be more posteriorly oriented along the inferior frontal gyrus, and you could slide all of them anteriorly, completely all the way forward, and they would all have the exact same name. So I think it's a little too reliant on relative location with other electrodes and not being as specific as it could be. So when we set out to develop our nomenclature, we had some clear-cut goals. So we came up with 7 of them, which I'll go through. And so now we move kind of from single letter to actually having 7 things, at least, that each one of our labels can help you identify. So before you see an MRI, before you see a reconstruction, when you see the name of that electrode, you will be able to determine all of these things from that. And I'm not going to read them all out because we'll talk about them a little bit. So for our entry points, we came up with a very simple parcellation method. So you can see the frontal lobe and the temporal lobe are more finely parcellated because those are the lobes that we are most frequently sampled with stereo. And then the parietal and the occipital lobes are less frequently sampled, so they are less finely parcellated. And then we also respect conserved sulcal and gyral patterns, so inferior middle frontal gyrus, and then the corresponding gyri in the temporal lobe as well. And then you can see primary motor cortex makes up our posterior most region for the frontal lobe, and then likewise sensory cortex being the most anterior region for the parietal lobe there. So then what we do is we clearly differentiate our entry and our target locations with a hyphen, and then we use acronyms. So as an example, AIF, AC is anterior, inferior frontal to anterior cingulate. So you can tell where the electrode has been implanted and where its target is. And if you have 2 points, you have a vector. So you know the exact orientation of that electrode without even needing to look at an MRI or a reconstruction. So there are some examples where there are, for ease of naming, we use a slightly different convention. So like amygdala is AMG, and we can get into a little bit of that. And then to denote left hemisphere electrodes, we simply put a prime or an apostrophe to demarcate left there. So those are our entry points, and then we have standard target labels for commonly sampled targets. So you can see MOF is mesial orbital frontal. We take our cingulate and we actually divide it into 3 subregions, which I'll talk about, and those are not just picked randomly, but there's specific anatomical markers that we use for that. We have cuneus, lingula, fusiform, amygdala, anterior and posterior hippocampus. So with just a few letters, we can clearly distinguish what our target points are for that. So it doesn't really go with so much like pin the tail on the donkey. You're not blindly kind of assigning things. You can take your electrode labels and you can design your reconstruction without even seeing where it's been placed. You can have a conceptual framework of where your electrodes are without even looking at any imaging. So here's an example here of one of our reconstructions, and you can see how much information as far as location of the electrode is kind of compacted into our acronyms that we use here. So we pay special attention to some particular structures, namely the amygdala and the cingulate, and based on Dr. Ketter's talk, you can tell why semiology is important and how seizures spread within a network is very important, and so we wanted to take that into consideration with our nomenclature. So you can see the green is the amygdala, the red is the central sulcus, and of course anterior to that is anterior insula, posterior to that is posterior insula, so you have your short gyri anteriorly, your long gyri posteriorly, and to give an example, so if we are placing electrodes in an orthogonal trajectory, if we just had the red, the target would just be AI for anterior insula. If you have 2 orthogonal targets in there, then we would prepend an A and a P for anterior and posterior to delineate the relative approximation of those electrodes within that structure. So at times when it is important to distinguish between electrodes that are very close to each other, our nomenclature can take that under consideration. Additionally, some centers, including ours, will use a transverse approach to access the insula and to get as many recording contacts within that structure as possible. So if we use that transverse approach, then we actually change the name of the target to LGI, or long gyrus of the insula. So not only does that let us know that it's in posterior insula, but also that it has a transverse target, and we can understand the exact the vector of that location there. So the reason why we pay so much attention to the insula is because with several very, very enlightening publications, this one I like particularly by Jobst, describes how seizures propagate within the insula and also from the insula. So what we know is that seizures that start in the insula oftentimes have no semiology associated with them whatsoever. It's not until they propagate out of the insula to other structures that we start to see any kind of clinical sign that the patient is having a seizure. And this paper goes through and it looks at different seizure patterns based on where that spread from the insula is. So, you know, when I mentioned meeting your patient for the first time and learning about their seizures, we're working our way backwards from where that might be, where that seizure semiology might be, but also if there is a mimicker within other deeper structures that could be spreading from there. And importantly, what we also know is that the insula, if a seizure starts within the insula, it does not spread throughout the insula, and it honestly does not even spread throughout all of the anterior, if that's where it starts, or the posterior. So you could miss an insula onset seizure, even if you have more than one electrode within that structure. So if you're suspecting an insular onset, it's very important that you have appropriate sampling of that structure to know for sure that you're not potentially missing that. And so that's why our nomenclature pays particularly close attention to that. Then for cingulate, you see we have it divided into 3 different structures: anterior, middle, and posterior. And how we define that anatomically is anterior is everything in front of the genu of the corpus callosum, and then the posterior is everything posterior to the fornix. And this was done because these boundaries do have some functional connectivity and seizure semiology implications to them. So we do know that the anterior cingulate gets significant input from the amygdala, so you want to make sure that you're sampling that network. Subgenual, you can have predominantly autonomic function, and then pregenual, you will have some emotional sensation of fear, euphoria, and then as far as semiology for other sections, middle cingulate can be involved in executive function, motor planning, and then posterior cingulate with memory function. And within the cingulate, it is highly interconnected and then has a lot of reciprocal connections with the other structures, more mesially, mesial temporal, insula, amygdala, and so forth. So oftentimes you are planning all of these trajectories in your head. Even though you may have a prime hypothesis, you want to make sure that you're not missing anything. So just to give an example, I'm going to breeze through this case fairly quickly, but this is a 20-year-old patient who was having seizures described as being aggressive, sometimes with secondary generalization. The story I heard was he wanted to be a police officer, and while he was on a ride-along with a police officer in the back seat, he became aggressive with that police officer because he was having a seizure and ended up getting handcuffed and arrested because of that. So skipping through some of our phase 1 workup, this was our hypothesis, and obviously based on this, you can tell we thought that there was a left lateralization and then a left frontal or temporal onset to this. So what we ended up finding was that, and whenever I see this, I stress out because I want to interpret it. But it's very small, so I'll just tell you that where the red line is, there's essentially 2 simultaneous onsets. One near the cingulate, and then another in mesial left temporal. So two areas that are anatomically far apart, but we are seeing near simultaneous onset with intracranial recording. So based on that, we decided to go with an RNS, and so you can see here's the reconstruction of that. So the lines are a little small, but you can see on the top right is cingulate, and then on the left side, you can see this temporal location of our RNS devices. So this patient remained intractable, had some benefit from RNS, but remained still having seizures. So he went back, and this is a patient of Dr. Clark's and Dr. Tyler Kabara, and what they actually did was they implanted stereo with the RNS still in place. And so what we got was simultaneous recordings of the stereo, plus you can see the artifact generated from the RNS. And you can see how delayed the RNS is based on where the red line is, where that seizure is starting, and then where the RNS was attempting to interrupt that activity. Based on our placement this time around, we also did some source localization with that, and we could actually see that there was very rapid spread from that cingulate area to the temporal lobe. And what we ended up identifying from that is a small dysplasia that we had missed before, right in the anterior cingulate. And you can actually see the black lines of the electrodes on the MRI kind of sandwiching that lesion. Even though we were that close, we were still seeing what appeared to be simultaneous spread from those areas, but with a couple extra modalities helping us out, we were able to move forward pretty confidently with a laser ablation, and this patient has been seizure-free, I think, for almost 2 years now. So knowing about your circuitry and knowing how these areas hang together is very important. We don't want to turn our patients into pincushions, but we also don't want to be overconfident in this cartoon of a dowsing rod, like with a single electrode, because we know exactly what we're doing. We want to be smart about our placement, and how we name our electrodes, I think, is also an important part of that, and I think we can do more to try and standardize that to help our patients. So if anyone here is interested in learning more about our nomenclature and wants to participate in a multi-center study, we are looking at recruiting more centers to do that. So that's my talk. And then I'd like to invite Drs. Wheelis and Dr. Ketterer up for our panel discussion. Thanks. Please. Not too far from lunch. Any questions?
Thank you so much for an amazing session. I completely agree with you, Jim, about how the surgical candidacy should be different for pediatric epilepsy patients. And the definition of drug-resistant epilepsy should not be so fixed to call it like failure of 2 appropriately chosen medication and uncontrolled seizure for 2 years. And some people really are fixated on that and very rigid. And I just want your opinion about the ESES, the DE-SWAS cases, where even if there's, would you consider that drug resistant? They usually are. And we used to just do only surgical workup only if they had a lesion. And I would love to hear your thoughts on that. And I mean, Amar, you happened to present a ESCS case. I think that was non-lesional, I'm assuming. And you dare to, with the little lead on the EEG, you dare to do the pre-surgical workup. So pre-surgical workup, and I have seen children where they have such active EEG, and it's unihemispheric. They have this continuous epileptiform discharges day and night. And when I presented the case, they said, "Oh, did you capture a seizure?" And I'm like, they don't seize because they are constantly spiking. And I just remember being criticized for bringing this child up for surgery when I have not captured a seizure? So I'd love to hear your thoughts.
So yeah, so one of the, so that exact question was actually addressed by the ILE subcommission. So if you go back, and I want to say, I'm trying to think when that was published, it must have been the early 2000s. But again, differentiating, pediatric kind of when to think about evaluation for, was very different than the adult side. But one of the key factors for pediatrics was any kind of developmental, regression or cognitive regression, which, most of those cases fall under, by definition, that they should be evaluated at a tertiary care, center, and seizures was not included in that definition. It was just the developmental kind of aspects. Again, not only just to evaluate for like his case, which is a gorgeous case, but just for, okay, etiologies and other stuff in the modern era that a lot of people are just not thinking about, for these kids as well too. So I think it's a different mindset. I think, unfortunately, it's less of it, I think, than there used to be years ago, but many tertiary care centers years ago were very proud of calling themselves epilepsy surgery centers, whereas I think nowadays we think of ourselves more as evaluating for, refractory epilepsy or these kind of issues. And yes, that may be, an option, but that's not all we do. And I always tell folks, if you go to centers, epilepsy surgery centers, it's kind of like, going to, a barbershop. If they just do one style of haircut, you know what you're going to walk out with. And that's not what most of us do. We go somewhere where they know how to do multiple different styles. And that's the same thing. You want to go where you get evaluated and where they're going to think about all the options that are available. And in the modern era, we haven't touched on it, but, even if they have surgery, I alluded to many of these kids are going to stay on medicine. If they have a device, they're going to stay on medicine. Even on the ketogenic diet, we know that it's only like, 1 in 10 that come off all medicines to stay seizure-free, so many of them are. Even our new genetically based therapies, as those roll out, most of those kids are going to stay on a medicine with it. So yes, we have these categories and buckets, but we've got to be thinking of all of them and tailoring them to our individual patient, right?
Thanks. So I'm going to ask the inverse problem, which has been alluded to before. So frequently now, I see people depending on one investigative study to not do surgery. So you'll see a lesion, they'll have the exact same semiology, and because one study shows potentially a few dipoles or something else somewhere, or the spec is incorrect, they'll go, well, it may be coming from two places. How do we address that within our community, knowing that India is having the same results with an interictal EEG and an MRI? When is it too much?
Yeah, you have to remind them of Willie Sutton, Dave, and Willie Sutton's law. And it applies to MRI lesions, right? When Willie, got out of jail for robbing banks, and he went right across the street to the local bank and robbed it, and he got caught, and they said, well, you just got out of jail. That's like the stupidest thing on the planet. His obvious answer was, that's where the money is. Yeah. And I think, we've learned that, if you have a lesion, it's always the guilty culprit until proven otherwise. The burden is on you proving, that it's not, and overwhelmingly, right? That you've got to have a very convincing, argument that this is not the sole cause. And even some of those that we say, okay, it may be driving a significant part of it. So even without this, you may still be better off, right? Even if it's not 100%. But the reality is it's almost always the cause. Yeah.
Anybody else?
Yeah, I think it's very difficult to change culture. And I think for years we have this equation of imaging, EEG, plus neuropsych, plus minus mag, PET, whatever. And the conclusion of this, okay, surgical, not surgical. In fact, there was the 5 cents score that was published a few years ago, which I'm not entirely opposed to, but I think as we talk about precision medicine and a tailored approach to patient care, I can't personally wrap my head around the idea of saying, well, you have this and you have that, therefore you're a surgical candidate or you're not. And we have tried, at least in our experience, to push the boundaries a little bit with bilateral polymicrogyria, even with some of the genetic patients, non-lesional ESES that we've operated on, to say, can we do more? And can we do things differently? But I don't know how you can scale that up or prove it without having large number of patients who have gone through this process, and you publish your outcomes and you say, well, you can actually do this differently.
Yeah, I would agree. I think it's a case of our reach exceeding our grasp in several cases where we collect so much data on these patients, terabytes and terabytes of data, and oftentimes it comes down to a clinical interpretation from a center that has a particular reliance on certain modalities and not others. And to your point about culture, then other institutions that maybe don't have a MEG, but they really like their pet and their SPECT, and that's how they do it. So I think it's really on us to try to be more collaborative across centers and figure out a way how we can get at these more complicated patients and do some objective analysis to figure out what is most helpful for particular types of
We have a few minutes.
epilepsy.
Okay.
Yeah.
So it's my question, actually more kind of a comment on your nomenclature thing. First of all, disclaimer, I don't have a better solution than you presented. So the problem which we tried this thing, that your nomenclature. So the problem became that, now think about it, if you have a bilateral stereo EEG implantation, so if you have a name electrode with 3 alphabets, then you put a hyphenation for the left or right. Then you have each electrode 1, 2, 3, 4. So by the time you get it on the computer screen, and you had that thing with, you basically need a microscope to look where the EEG activity is coming from.
Yeah.
That's such a big problem.
It is a
So-
problem.
So how do you? I could not come with an answer. I admitted that to
Well,
start with. So what do you do about that?
Yeah, I'll tell you what we did. That was actually a mistake on my slide.
Oh, okay.
And I had corrected and I sent another slide in. But anyways, the hyphen is at the very beginning. So we essentially moved it so that it was at the very beginning. And when we list our electrodes, typically we're listing them right or left, and then the contralateral side. So so you can see everything kind of prepended that way. And that was how we kept it from kind of getting buried between the transition between the last letter and then the number of the electrodes. And if it's a bipolar montage, then there's multiple numbers. Yeah. So that has worked well for us. And I think that, again, it'll come down to the argument of it's either going to be some kind of single letter, which is super vague, and I don't want to get death threats from neurosurgeons who just love their single letter nomenclature so much. But any other nomenclature that's going to have more information, we're going to have to figure out what makes the most sense. But for us, to answer your question, we moved it to the very beginning, and it's more clearly seen that way.
Thank you.
All right, I'm going to put in one short plug for the nomenclature we're doing, because one of the things I will say is, since we started using it, when we talk about a patient in our surgical case conference and the neurologist has put up their tentative things, by the time we do our first surgical planning, I usually have all the electrodes exactly where they were thinking, because I know where they want to start, I know where they want to end, and then so then my tweaks are, okay, well, I don't like this or angle or whatever, and so I think that it's actually worked beautifully. So I do have one question, and we're a room full of people who take care of epilepsy, and it's really funny because in this room, when we talk about lesions, we're usually talking about polymicrogyria, we're talking about cortical dysplasias. Coming from a general pediatric neurosurgery world, usually when we're talking about lesions, we're talking about those little things that enhance that we think we should take out. And having, through my years, been in a practice where if surgeon A was on call and that lesion came in and that kid had presented with a seizure, there was no discussion about how long they'd been having epilepsy, whether or not they had epilepsy, was this his first time seizure, and they went to surgery. And then if it was surgeon B, it was like, oh, wow, man, okay, well, this kid's actually been having these weird auras for the last year. We need to funnel this kid into the epilepsy workup world. And then you had surgeon C, who, even though it was a first-time onset seizure and there was no history, was still like, oh, no, we're going to go do the whole epilepsy thing. So I guess my question is, from this group, how do we help educate the pediatric neurosurgeons who get that funny little thing that comes in on call as to who should go through the process and who should just get their surgery because we've got an enhancing lesion, we should hurry up and get out.
I was going to say, I think, so I think two things. One is, and I would use the cardiology model because I hate to say this, they deal with a simpler organ, so they're ahead of us, I think, year-wise, because it's been easier for them. But the pediatric cardiology heart institute model for decades now has been that the neurosurgeons basically, the cardiothoracic surgeons live with their cardiology colleagues, and they talk about everything together, and they're very joined at the hip, if you will, because it benefits both of them. So I think one, in pediatric neuroscience, we've got to do that. We've got to have neuroscience institutes where the neurosurgeons that do this kind of stuff have easy communication with their neurology colleagues, and they're bumping into each other, so that if you are on call and you have a patient, the next day you're bumping into Dave or Cliff or whoever and say like, oh, hey, I think this is, really a malignant type lesion. So I've got to, this is one that I'm going to do surgery on. I'm not sure if they had a seizure or not. Do you need to be involved? And you can move on versus, oh, this is a low grade lesion. And can you talk to this family? Because I'm really wondering if they haven't had spells or whatever, or maybe this is a lesion that has genetic implications. And can you please help me with that? Because we still may do surgery, but that's going to be helpful for the family to know, going forward, whether they want to have other kids or whether it even affects this kid's prognosis as well. So I think in my view, that kind of the team is the way you solve this at the end of the day. The surgeons that are kind of based, off in one area, and the neurologists in another area is where you see this kind of dichotomy.
Yeah, I think that, I forget who the speaker was, but they made a Goldilocks and the Three Bears analogy where, you need to take out just the right amount of tissue. And I think that the more that we get our patients plugged into post-resection neuropsych testing and we get better at targeting these lesions, we can show that really there should be more thought put into these patients before just, telling their parents, hey, by the way, while you were in the restroom, we took your kid to the OR and, cut out that lesion. So don't act shocked. Don't act like you haven't thought about doing that before. So I think there should be a way, to Dr. Wheelis' point, that we could at least fast track those patients for a reasonable consideration before they go to the OR. Yeah.
I just have one question comment on the nomenclature. I think every time we have this argument about what the nomenclature should be, which is all the time, I think we're forgetting is a lot of nomenclatures and classification schemes and scales. They're really based on what you intend to do, right? And the old stereo EEG done in the 50s in France was, one, all orthogonal because the x-rays had to be orthogonal. Mm-hmm. We don't need to do that anymore. We have robotics. Two, they were built to really design how you're going to extend your temporal lobectomy to grab other things that may be part of the seizure circuit. So they're designed for open operations in an age where we're not always doing those open operations. So one of the problems with a lot of the nomenclatures now is they're not really designing or thinking that we're going to ablate that corridor. And your posterior insula is a good example. I mean, a coronally based sample that's going to the spherotemporal gyrus and the insula, it's not going to be a very effective ablative corridor. So one thing to add to the complexity is to really consider which nomenclature we're going to use based on how we intend to treat the patient. And the other issue is parcellization, because those some of your gyri you're dealing with are 5 centimeters long. They're going to be way beyond what an ablator can do. One look at parcellization that's being done at Yale, and they're actually breaking the frontal lobe down into like 5-6 places and things like that. It's hopefully out in the next year or two. But that's the first time I've seen some plan getting close to what we're doing these days in epilepsy surgery. So.
Yeah, I think that's a great point, especially about the orthogonal trajectories early on. And then with the intent, the other thing that we really thought about is usability, especially for patients that just don't have normal anatomy. They don't have normal cortices. A computer algorithm parcellation would not be able to accurately parcellate out those patients that have had prior surgeries, that have already had a resection. They may not even have a left frontal lobe. So how you're going about setting that out. There needs to be some degree of flexibility. And even on scalp EEG, it's all based on percentages. They measure an area and then they mark percentage-wise, but there seems to be this, it's not specific enough. It needs to be super specific, but I think it would become unusable at that point if it gets to be reliant on computer parcelization or if it gets too complex. That was at least our approach, in kind of thinking about walking that boundary between simplicity, usability, but also having enough information for it to be worth the battle to standardization.
Yeah, I was actually going to say something similar. And we looked at parcellation because of because we submit as well. And they have at least good parcellation literature. They have 8 different ways of parcellating the brain that at least 12 different centers are using. So I think I totally agree, but I think that's after the initial stages, and we have discussed this, I think all of us have to get together and figure out what could be the best foundational way, and then we can put in our variants. Yeah.
Okay, I think it's lunchtime. Yeah, all right. Thanks, everybody. And thank you so much for our speakers for this panel.